She's our new thoracic surgeon. We're very happy to have her.
I am a new thoracic surgeon, as you know, probably some of you know, probably majority or everyone knows that Dr. Hypertension is retiring in December. So we have a little bit of overlap with him right now, but I wanted to kind of catch up a little bit as to just talk a little bit about thoracic surgery, how kind of I do some things, and just explain some of the more critical parts which over my time of being a surgeon, then I came across, and I think they're always worth emphasizing and making it just easier so we're always on the same page. So just a little bit, this is like literally thoracic surgery is pretty much everything in the chest except for the heart and aorta, because the heart and aorta becomes cardiac surgery, or if it's descending aorta, then it's going to be vascular, or a combination of those two. So I don't deal with this, but everything else that's there, I can answer your questions, I can help with this, I can fix it, or I can say, unfortunately, can't really do anything much about it. The two most common approaches, thoracoscopy or VATS, and thoracotomy. Thoracotomy is the more traditional one, things that have been around since, for like about 90 years. And thoracoscopy is probably about 20 years old or something like this. And now more recently, in the past 5 to 10 years, robotic approach has come in play. It's very, in terms of incisions, it's very similar to thoracoscopy. And pretty much the time course and how patient recovers is very, very similar to thoracoscopy as well. Now I have a couple of videos which I'll put them later if there is time and you want to watch them. One of them is the robotic lung resection, and the other one is mediastinal mass resection, also robotic, because it's kind of really almost like deep right here, kind of right at the base of the neck, but still in the chest, or it's right at the very, very tip of the chest. So we'll skip this for now. So just a couple of things. So at the end, so the bottom line, when the patient gets here, and this is probably like the most important part that, over a year that I've discovered, at the end of surgery, patient will be here with the chest tube. And how we manage the chest tube, just to remind you, there's more than one way to skin a cat. So what I do with the chest tube may be different than what Dr. Fabinger tells you. He understands and how he does it, than KJ does, and somebody else, or the trauma service does. But the bottom line, we don't really know which one is the only best way and which one is the wrong way. If you have a couple surgeons in the room, they will argue among themselves. Like, is it supposed to be on suction? Should it be on this suction? Should it be on water seal? Should it be clamped? Or shouldn't be clamped? But just to explain a little bit what we have, I believe at this hospital now, although there is a Pluravax, which is the red and blue one, but they should be kind of phasing out, because this is just because some of these were in back order. But there are two things. There is atrium oasis and there is atrium ocean. One is a dry suction and one is a wet suction. Easy way for me to remember is this. Ocean is water, so it's a wet suction. You got to fill it up with water. So it's about 200 cc's of water that you first have to fill it in this column, and that's the one that's going to be bubbling when you put it on suction. And oasis, it's in the desert. It's dry, there is no water, so it's dry suction. Here, you fill it up with just a little tube that comes together with an atrium, and then just going to be a little bit of water right here. So majority, like 99% of the patients will have a chest tube. Right now, there is a patient on the floor from yesterday. She has a drain, so it's not a real chest tube, but just because I didn't have to do any lung resuction. And this is just to expand the lungs at the end, and just to make sure that whatever drainage there is, it's going to be evacuated. So how do we, so the most critical part about the chest tube limitation is to make sure it's not clamped, or if it's clamped, that everyone knows that it's clamped for a specific reason and you know what to look for. So just to review, who wants to go at this? Which one is wet one, which one is dry one? Correct, yeah. So as you can see, they all have kind of like A, B, C, and D letters assigned to them, and this is, if you really want to know what they stand for, this is what they stand for. This is where you look for suction, it's going to be A. It's going to be A on the dry one, and it's just this like little dial. And it's going to be this column A right here. So they're all labeled the same way. So if it's A in the wet one, it's going to be the same A over there. Water seal is B. Air leak, this is where you look for an air leak chamber. This is where you look for an air leak. It's going to be C, and the collection chamber where all the drainage comes in. So what's the significance of the chest tube? And it took me took me some time until I actually figured out. It became that understanding became much more intuitive. So what happens when there is a pneumothorax or collapsed lung? Some of that air that you inhale with every breath goes in, expands your lung. And when you go to exhale, that lung kind of gets collapsed a little bit and you expel that air. Unfortunately, if you have a hole, such as someone punctured you in the lung, or I cut some of the lung out, there is going to be interruption in that outer surface of the lung. So as you inhale some air, that air is going to escape through these holes and it's going to sit here. When you go to exhale, that air is not going to go back through the same hole and come out through your mouth or your nose. And this is what happens in the normal lung, but in here it keeps accumulating. So another breath, a little more air. Another breath, a little more air. Eventually, enough air accumulates that it starts collapsing the lung. So what we do, we place a chest tube so we can evacuate that extra air. Once it's out and it's not pushing in the lung anymore, the lung can expand. So why this is important is because if we have any sort of malfunction with the chest tube in a patient who has an air leak, it's going to cause problems. There are many opportunities for the tube to be kinked, clamped, occluded, or whatever happens. But essentially, it's going to simulate as if the tube has been removed and it's out. So this is just to point out a couple things. Chest tube is long, unfortunately. I think if we manage to make it shorter, then it's going to alleviate some of this. You can kink at the tube, at the patient itself. The tube is sitting very high, suddenly it's gravity dependent and kind of kinks like this, and now it's essentially clamped tube. The dressing sometimes can cover so much stuff under it that you're not always recognizing that it may be kinked right here, or maybe dissociated and maybe occluded with the tape kind of right against when the tube separates, and some of the dressing can occlude it. But from the outside, if you have a bunch of stuff there, you're not actually able to see this. Then, as the clamp sometimes can slide in and out, and that's, if you didn't check that, that can also cause that will essentially simulate clamp time. When this long tubing gets wrapped around the rail, that can also kink the tubing. It can kink right here. The bed can run over the tube. Had seen it plenty of times, especially with the transport. The patient can lay on the tube because of you just moved him from one bed to another, and now the patient's chest tube from the right side is hanging out from the left side. So all these things. So when I come and I round, I constantly check, where's the tube? Is it kinked? Is it free? Is it something else is happening? Now, a couple other things which are not as obvious that can simulate the same thing. Essentially, that the tube is clamped. One of them is this. This connector here has that little valve, and you can either open or close it. When it's in a closed position, kind of like this, that's the tube is clamped. If you didn't pay attention to it, or someone kind of, oh, what do I do with this? And maybe it was part open and part closed, or something like this, and someone twisted it, or it just got caught somewhere and it shifted, this is going to simulate this. So if you check everything else, you say things should be okay. This is one part that's kind of hidden, and you have to really know about this and check on this. And the other place is the actual suction. So I'd seen chest tubes connected, everything is fine, connected, and then this tubing suction comes up here, but then no one actually turns on suction. So it becomes a closed system, so everything is perfect, nothing's kinked, everything's open, everything's connected well, but now this is where the clamp essentially is. And then so just different regulators, this one or that one, or sometimes we switch it too often too early, and that becomes essentially a clamp tube. So it's just like a couple things which you don't always think of this, but they become very important. So again, two practical things. When do you worry about? Clearly bleeding, right? So anything about 200 cc's or a little bit more, every hour for several hours, 2 to 3 hours. If this is how much there is drainage, it's a concern that there is an ongoing bleed. So you may actually see only 200 come out here, but there may be much more accumulating in the chest just because patient is not moving and things may not be draining as easily because they're laying down. So if you see bleeding, and also another sign that there is something is wrong is hypertension, which does not respond to the usual some of the fluids, and also as the patient wakes up from anesthesia, they become more aware that their blood pressure should actually go up. But if you see that they're becoming hypertensive and there is much more drainage. So that's a word sign. I have 3 pictures here which basically talk about what kind of drainage can be there, right? So if you have 200, 300 cc's and it's very clear yellow fluid, that's fine. You know, this is typically when a patient has an effusion or maybe pneumonia and we place a chest tube, and it'll drain like 2 liters in a matter of like half an hour. Patient feels better, but this is not blood. Kool-Aid color. This is something that I see frequently. We do this, drains a bunch, and then I do TPA. When I do TPA, the fluid starts turning a more red color, and it's not. It's kind of translucent. If you look at the tubing where the fluid is sitting, you can almost see that it's sort of transparent, and it is more like a Kool-Aid color. It's kind of brighter red. And now the last one, when it's actual bleeding, it's when it's really dark blood in the tubing, and sometimes you can actually see clots forming in the tubing as they're trying to push this all down. You see that there are these clots, and you kind of have to squeeze it, and it takes longer for it to drain. So that's the real bleeding. Other things. So now this is back to the chest tube. Breathing difficulties. So if we clamp the chest tube or whatever happened, but it simulates the chest tube clamped when the air is not able to evacuate and escape, as it's going to build up inside the chest, now you can see some of the changes. That air is going to find a way to escape. If you have an incision, it's going to start dissecting through the tissues, through the muscle, under the skin, and it'll go everywhere. It'll go in the chest, it'll go in the neck. It can be as severe as this guy in the corner over there when the eyes get shut. I'm sure you guys seen it. It's not common, but you have seen it. So what's the thing that you do? Check the chest tube. It's not clamped. It's not he's not laying on it. Something else didn't happen. That's the first thing. Now the second picture shows when it's not as severe, but this is something that after lung surgery, you know, patient is doing fine for the first couple hours, and then maybe they cough or something else happens, and you can see that one side starts swelling up, and it's kind of like it all turns into a little pillow. If you look at the person, if you just look on one side of the chest, sometimes it's hard to figure out, is it normal, is it not normal? But thank God we have a second side to compare it to. Is you look at both sides, and you'll see the difference. The guy in room 11 has a little, not 11, 10 or 11. He has a little bit, his left chest is more kind of swollen up. What does it feel like? It feels like Rice Krispies if you actually push on it. If you listen with a stethoscope, you're gonna hear this crunching, crunch with, not even with breathing, it just as you move your stethoscope around with your pushing on it, you have this, just basically air dissecting through the tissue. It's not really dangerous. It's scary when patients see this. It's scary when suddenly your face swollen, and then your eyes get swollen and you can't really see anything, but it's not really dangerous to the patient. It's not painful also. So I try to reassure the patient, make sure a chest tube is working. Sometimes have to place a second chest tube because even though everything external to the chest can be fine, there may be a clot sitting in the chest tube deeper in, which I'm not really seeing. So sometimes have to replace the chest tube to make sure all that air is going to evacuate. So chest tube. Make sure chest tube, but usually in this case I place it, if the chest tube was on water, so I'll place it on suction. Or if it's already on suction, the usual kind of minus 20 centimeters of water, I'll increase the suction just to help suck out that air. What suction does, it basically helps you to kind of move all that air or fluid, whatever it is, through the tube. It's a long tube, so it takes a little, it creates a significant resistance. So a couple other things that can happen. Again, a lot of it goes back to the chest tube. Everything's going fine. Suddenly you come in and you see that the patient who had maybe minimal air leak or maybe no air leak at all, suddenly there is a lot of blowing, kind of bubbling going on. In my experience, it's mostly because the chest tube got disconnected, especially if it was on suction and somewhere it just came apart. Typically, it comes apart around near the patient. Either it's completely separated or it became loose enough that now it's kind of sucking air. Very rarely it may be something that is kind of happening that's related to something that happened in the chest. So took out some of the lung, there are use staplers, so you staple it and it leaves a row of staples, and patients have really bad emphysema and the lung is very friable, that staples can tear through the lung. So it's not the chest tube problem, it's actually internal problem because now as those staples kind of fell off, it opened up a hole. Now it's not a tiny hole; it's a bigger hole through which air is shuttling a much more larger volume of it gets through. And the other thing that is probably the most common complication that I talk to patients about, so I usually tell patients about pneumonia, infection, and prolonged air leak, especially people who have some COPD and whose lungs are not as healthy, because they might have to be going home with the chest tube, and cardiac arrhythmias, typically atrial fibrillation. A couple years ago, I actually wrote a paper on this where we looked at the risk stratification of patients with atrial fibrillation. Older people, age is one of the risk factors for atrial fibrillation, but majority of this triggered by surgery, by surgical stress, by dissecting right where the veins are, which is the main source of atrial fibrillation. So if I pull on it and I staple and I cut it and I dissect it, it just triggers that cycle. And then normally just some medication treatment, if it's stable AFib, otherwise some medications will calm down, either convert or slow down the rate enough that it'll be much better tolerated, and then they'll go back into sinus pretty quickly. Within a day or 2 days, they're typically in sinus. So post-op course, some of the things that I specifically focus on is pain control, and it's trimodality. It's narcotics, non-narcotics, like Tylenol and ibuprofen, unless patients for some reason cannot have it, either because they have liver disease or they have gastritis. And early chest tube removal, just because it is, it's small, but it can cause significant discomfort and a lot of pain associated with that. Incentive spirometer use, super critical, because this is the thing that's going to decrease your chances of pneumonia. Brushing teeth, hugely big association between not brushing teeth and developing pneumonia postoperatively. Not just in thoracic patients, pretty much in any patient who's hospitalized. Just because we have a bunch of bacteria in our teeth that grows, if you don't clean it, you're gonna aspirate. Especially in older people who are much more likely to aspirate, they'll have increased risk of pneumonia. And early ambulation. Early ambulation, as we all know, 40, 50 years ago, everyone got bed rest. Everyone was on bed rest for I don't know how many weeks, and then they're hardly able to get out of bed and walk because they lost so much muscle mass. So now, early ambulation, ideally the day of surgery. So if it's an early operation, we kind of want to get them out of bed very quickly, very early, so that they remain active and they don't lose as much muscle mass. Expected post-op course for lobectomy, between 1 and 3 days, on average, probably like 2.5 days in the hospital. Empyema, these are variable because they can be super sick when they get into the hospital, depending how you treat them, what exactly they do, were they younger, were they older, what other things. It's a lot less predictable time course. Blood resection either for pneumothorax or if they have COPD with big bulla, you typically a couple days in the hospital. Mediastinal mass, if it's not open, 1 day in the hospital. This is what I tell patients, you're going to be going home the following day. The lady in 8 is a little bit different because she has a lot of other things, kind of like liver failure, so that may hold her up a little bit longer, but it's not going to be really related to surgery. And a lung biopsy is typically 1 day only as well.
So when you say early ambulation, do you put orders in through the staff so they can ambulate on suction, off suction? What is your protocol there?
So typically, I'll put patients for lung resection. It'll typically be off suction when they get to the floor, and then they can ambulate off suction. Pretty much everyone, unless there is something very specific, I'll keep patients on suction. I tend to use less suction maybe than some other people. So I'll have a specific reason why I want suction. Typically they should be off suction and on water seal, and therefore they can ambulate.
Okay, but if they're on suction?
If they're on suction, I'll specify they can be off suction for ambulation.
Okay,
and most of them will be, that will be like a
Yeah, that's what I'm thinking. A lot of times we don't get that specific. It'll say activity is tolerated, but it won't say I can take them off suction.
So
that's good.
I'm working on my adjusting my order set.
Okay, good.
It's a work in progress because there's always something like, oh, I actually have to change that.
Yeah.
So I'll add that. I'll make that.
That would be good because I think that currently they're used to not doing it unless there's a specific order to ambulate them off suction.
I'll write it down just so I can
Thank you.
specifically pay attention to that.
What other
Any, anything else?
If,
Yeah.
our guy in 11 has a Heimlich valve now. We had a thing come up last night, so he coughed and a lot of stuff just spewed out of the tip.
Okay.
Can that tip be covered or not?
It shouldn't be covered, because if you cover it with something like plastic or glove or something, then you're not able to really evacuate air as efficiently.
They covered it with some gauze. So
The gauze, right, so I was gonna say, with something that's absorbent but still lets the air through, yes, that's fine.
we're covering with gauze is okay.
Mhm.
Yeah, because it kind of just went all over and hit people.
Yeah.
That was not nice.
That's when I kind of tape it, hoping it'll have like stuff over it, you know, like shirt or what, like a t-shirt. But if it was kind of exposed or something, then yeah, it'll be like a fountain.
And chest tube dressing, do you have a particular way you want
I
us
prefer
to?
no chest tube dressing, because then it's just easier to see what's there, what's under, you know, where the tube goes in. Just like I prefer no tape on the connector, because it's easier to see if there is a problem. Otherwise, I've seen plenty of examples where there's a big dressing here, and then there is a big dressing on the connector, kind of like the wrap, and then the tube is completely apart under all this. But the tape is holding it here, the tape is holding it there, the thing in between is disconnected and doing whatever. And it takes you like 5 minutes to take it off sometimes and figure out what's going on. I prefer as little dressing as possible. Plus, it also makes patients look like if I have a big dressing, I must have something big. If I have little dressing or no dressing, it's all good.
So do your patients come back from the OR with no dressing?
Typically no dressing. Sometimes the chest tube site will be, because I use a couple instruments through the lower incision, and I have to enlarge it, so that if the incision is bigger than the chest tube, because of this, it'll leak a little bit. So if it leaks, I put like a little dressing over it.
Okay.
And if if they come in because everything is looking good when they get out and it starts leaking, you can put like a little dressing in.
Okay.
Yes. Anything else?
Do you mind what kind of dressing you put on?
Not, I don't really,
Okay.
I mean, dressing is a dressing, so.
Okay. Just wondered.
As long as it's not big, but don't put like,
Yeah,
don't put like 3 ABDs on it, because then it's gonna look like he has a baby there.
They develop an air leak during the night. Do
Mhm.
you want us teaching you about that?
If they just develop like, it looked good and then there is a little bit of an air leak, probably not, but if they start like, the emphysema, yeah, that one, yes, because then we can interfere a little bit earlier before it starts spreading into the face and like the eyes and everything. So, and the response is very likely to be, oh, let's put him on suction, because the chances are the patient will be on water seal. So we'll just put it on suction. Make sure tube is unkinked, suction just to see how much air to help that air evacuate. All right.
So what if I take a picture of that water seal versus